This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with practices in Midtown Manhattan and Wayne, New Jersey. My co-host, Dr. Marina Kurian, is a minimally invasive surgeon and obesity surgeon practicing in New York City. Unfortunately, she's on call, so sometimes doctors can't quite make where they're supposed to be. I miss her a lot and we'll have her back as soon as possible. Today we have a wonderful show for you. We have talked intermittently about mental health during the COVID pandemic, and today we have two experts, one from internal medicine and one from psychiatry. And we are going to talk about how people can get help in the primary care and urgent care settings. Dr. Hilary Beberman is a concierge family physician who practices integrative and women's health in Great Neck, associated with Health Bridge in Long Island. And Dr. Tamir Aldad is a psychiatrist who holds an MBA. He's founder and CEO of Mindful Urgent Care Psychiatry, which has practice locations in New York, New Jersey, and Illinois. We're going to meet our guests real soon, so please share and like and tag your friends who will be interested in this really important conversation with our guests. We are very grateful. We have two corporate sponsors. It's like triples. We're doubling. We have immense gratitude to ENT and Allergy Associates, which has 40 plus locations in New York City, Long Island, Westchester, and New Jersey. And you can access high quality ear, nose, and throat and allergy care on the same day or the next day just by going online at www.entandallergy.com. And our new sponsor, thank you very much, is Comfort Ear, which is a natural moisturizing ear drop. This is a great over-the-counter product that I happen to use. I have no relationship with them, but I advise my patients with itchy ears or scaly wax to get this. It's not for treating infections or if you have a hole in your eardrum, but the normal scaly wax or itch that's so irritating, this is really nice. It was developed by a physician, Dr. Yashbe, and she and her team have brought this to the market, and we're very grateful to them for their sponsorship. Again, please like and share and tag your friends. Let's talk a little bit about where we are with COVID. The Delta variant of COVID is everywhere. It accounts for 99% of the new cases in the United Kingdom. The WHO, the World Health Organization, is recommending continuing to wear a mask if you're not around people with whom you are intimate in your family, even if you're fully vaccinated, and that's of course particularly in an indoor or a crowded setting. The CDC does not recommend that yet, but you can see on the world map in this picture that the red and the orange are high prevalence of the Delta variant. The yellow is moderate prevalence of Delta variant. You can see that there's Delta variant all over the world. In the United States, we went from 2% of COVID cases being of the Delta variant last month to 10% 2 weeks ago to now 20% of our COVID cases, and inching closer to 30% carry the Delta variant. 50% of the cases in Israel are this variant. So this is real. We are unfortunately continuing to see COVID around the world. So even though we may be tired of it, it is not tired of us. Very, very unfortunately, Brazil has passed over 500,000 deaths, and there is no sign of let up. And unfortunately, we are seeing those deaths as we did in other parts of the world, in the most vulnerable populations in particular. Brazil has 2.7% of the world population, but has had 13% of all the COVID fatalities. So this is real. Please continue to pay attention to it. Worldwide, there have been almost 180 million total cases of COVID. There are currently 400,000 new daily cases of COVID. We've seen 3.9 million total deaths worldwide, and we're seeing 8,600 new daily deaths that are reported worldwide. Vaccination front, 2.92 billion total vaccinations, with daily 42 million new vaccines. So vaccines do work. New Jersey, the state of New Jersey, had its first day since July 30th, 2020 of no in-hospital COVID deaths. There were no new cases or deaths in over half of Michigan's counties this week. And cases, as you can see by this graph, have fallen precipitously in the United States. However, you can't just say, oh, New York is fine because 70% are vaccinated, for example. The two maps that I'm going to show next show that in areas of the US where vaccination rates are high, we are seeing fewer and fewer cases of COVID. So that means the dark green on the left, which is high vaccination rates, you can see correspond to the blue or the yellow low case counts, whereas the lighter shaded states correspond to the orange and red high case counts. So vaccinations really do work. Now, each area is different. I saw a map of New York City in the New York Times today. And, one of my patients came from the Upper West Side and she said, oh, 110% of the people on the Upper West Side of Manhattan are vaccinated. And I think she was right. But we're seeing that there are areas of high vaccination, low case counts, even by zip code. So really, please do get vaccinated. Shockingly, more than 1 in 10 people in the United States are not showing up for their second dose of a 2-shot vaccine, which would be the Pfizer vaccine or the Moderna vaccine. And that dramatically reduces their immunity because the second shot gives you 10 times the protection. So a lot of them, at least as far as physicians are aware, a lot of them are concerned about the side effects. And that slide that I had up showed the side effects. But really, they last a day, maybe 2, rarely a couple more days. It's like being a little bit sick or getting a bad cold or a touch of the flu for a couple of days, and then you're fine. And once you have those symptoms of muscle aches, fatigue, maybe a little feverish, you can go ahead and take some ibuprofen or acetaminophen and treat the symptoms while you still maintain the immunity. There was a scare recently about a heart condition following vaccination. So the FDA, the Food and Drug Administration here in the United States, added a warning to the Moderna and Pfizer vaccines for myocarditis and pericarditis, which is inflammation of the heart and inflammation of the sac that holds the heart. But really, out of 300 million vaccines administered, there have been only 1,200 reports and 300 confirmed cases of either type of this inflammation of the heart. And we know that COVID itself, the infection, can cause heart conditions like this. So again, as with every week of this show, and all physicians and all healthcare providers, please get vaccinated. Please continue to wear a mask, particularly if you are going to be close and in indoor settings with people who are not vaccinated. And please continue to help us fight this really terrible disease. We are live on Facebook, on YouTube, on Twitter, on Sri Srinivasan's LinkedIn page. Please like and share and tag your friends who will be interested. We are going to be carried, as we are, every Monday from 2 to 3 p.m. Eastern on WBAI 99.5 FM and WBAI.org. It's really a different experience to just listen to the audio. I actually love it. I think you get it in a different way. So please, thank you for your support as viewers and as listeners. Let's meet our guests. So this week's show is on mental health. And our guests are Dr. Hilary Beberman, who is a concierge family physician and practices integrative and women's health in Great Neck, New York, and Dr. Tamir Aldad, who is a psychiatrist and founder and CEO of Mindful Urgent Care, which provides same-day or next-day psychiatry care in many locations in New York, New Jersey, and Illinois. So welcome to the show.
Thank you.
Thank you for having me.
Yeah, I'm very excited to see you. Marina was so excited about having you on, and she really does regret not being here. We have so much to cover. I think, mental health has been at the forefront as we have encountered this pandemic. So I must say a silver lining of the pandemic is that we are talking more openly about things that perhaps were not spoken about very well. Let's start by asking you, Hilary, I said you practice integrative medicine. What does that mean?
Well, integrative medicine is really more of an approach to medicine. And it takes into account the whole person, and there's a partnership between the practitioner and the patient. And it's integrative in the sense that we take into account all things that would contribute to a patient's wellness. The mind, spirit, body, everything. In addition to just if someone had a stomach ache, we would just look at not only why they have any reason that may cause it besides the physical medical reasons. But it's important that we're still evidence-based, still use conventional medicine to look and diagnose somebody's symptoms. However, an integrative physician would be open to other aspects of what might contribute to an ailment such as a stomach ache.
Thank you. I really appreciate it because as we know, a lot of times other illnesses do present as sort of the patient says, oh, I have a tummy ache, I have a headache, I have a this, I have a that. And it's something underlying that really needs a little bit of time and effort to appreciate. We have Mental Health Awareness Month, we have this month, we have that month. We've talked about this a million times, but there's still so much stigma attached to carrying a mental health diagnosis. So Tamir, can you talk to us about stigma and how we try to erase that in ourselves and our communities?
Yeah, I think stigma comes from two places. One is education. There's a lot of room for improvement in educating patients, individuals, families, friends, relatives, anyone that has access to someone who has any sort of mental health issue, educating them and normalizing those symptoms the same way you would do with the patient that complained of, like you said, you guys are mentioning a tummy ache or chest pain or shortness of breath or a cough, normalizing that mental health symptoms are no different. So there's a huge component of education that's required. And the second component is access to care. Once somebody knows that they have an issue, there's also an access to care problem where they don't know where to turn, whereas you would likely feel more comfortable going to your family physician or your internist for a tummy ache or chest pain or a cough. If you're feeling depressed, suicidal, violent, aggressive, anxious, having panic attacks, not everyone really knows where they could go. So improving access to care would make a difference with stigma, and normalizing it by educating people that it's no different than any other symptom would help a lot as well.
I think we have people watching from all over the world. Somebody checked in from Mumbai and said we are in a mental health crisis across the world. That was Manav Hirani. Thank you for watching. Joe Diamond is watching. He's a cardiologist in Long Island. And I think All of us physicians, whether we paid attention in psych rotation or not, understand the psychiatric component to organic or to physical ailments. We have Sucharita watching from Delaware. We looked at the data from before the pandemic of mental health issues. And before the pandemic, about 21% of US adults experienced some form of mental illness. And this was from 2019. So this was a fifth of our country before everything got crazy in March, April of last year. We noticed that about the prevalence of acute mental illness was more prevalent in women, that younger adults had the highest prevalence of this, even though in practice we saw a lot of elderly who ended up being very isolated and got quite depressed and anxious during this time. And then we saw that there was a higher prevalence of reporting mental health issues in white adults, followed by Hispanic and Black adults, and the prevalence was lowest among Asians. And I will tell you, as an Asian American, I think that is because we are acculturated to hiding any negative emotion, and we are acculturated to not talking about it. And we would much rather have a burst appendix than depression or anxiety. Right. And I think you see that in a lot, but you see that in Asian cultures. So can we talk? Yeah, go ahead, Tamir.
Well, I was going to say, I mean, I'm first generation. I could agree with that as well, that it's very different from, in other countries, mental health is stigmatized. It's a sign of weakness, and vocalizing symptoms is kind of frowned upon. So, I'm not surprised that, at those numbers. But what's interesting is if you look at today's Wall Street Journal, there's an article talking about the expected surge in the mental health crisis post-COVID, which is a real serious issue because a lot of mental health was neglected over the last 18 months. And what we're about to see is even people that have suppressed their symptoms, they're going to present with worse symptoms because they've neglected it for so long. And we don't, it's only going to get worse, at least in the near future, because a lot of people haven't had access to care, haven't sought care. If they come from families or cultures and backgrounds where it's taboo, they haven't said anything, and now it's like bubbling over. And personally, I subspecialize in addiction and substance use. We saw a ton of substance use during the pandemic because everyone was self-medicating. And now those people, I'm expecting, will start coming out of the woodworks seeking care for their addiction and substance use. So
we use this term self-medicating. And I know we have physicians in the audience, but we have non-physicians and non-nurses in the audience too. So when we say self-medicating, do we mean they're going and taking some pills by themselves, or what do you mean by self-medicating?
Right. So using the newer terminology, it could be either substance use or substance misuse. So if it's a prescribed medication and they're taking it without a physician's recommendation, it would be substance misuse. And what they're doing is they're trying to treat their own symptoms without seeking medical care. And then the other term would be substance use. That would be using an illicit substance to treat your own symptoms.
And I think there are, the reason we have both a family physician on and a psychiatrist on is a lot of times people will present with physical symptoms, right? So Hillary, can you talk to us about how your patients might present and how you start evaluating them based on what they're presenting with and what you think is going on?
Yes, absolutely. Just to your and Dr. Ahmed's point, because especially this year, people have had no access to mental health, and that along with the stigma of, coming forward and saying I'm anxious or I'm depressed, it's hard for people to do that, especially if you're depressed. It's hard for them to even go outside, let alone find a psychiatrist or a mental health provider for psychodynamic therapy. So frequently during this year, I would have people who would come in and they're just saying, I don't feel good. I have brain fog, or I feel numb. Like I just can't feel I'm not happy. I'm not sad. I just feel numb, or I'm tired. I'm gaining weight. All these physical symptoms. They want me to check their thyroid. When in fact it is a manifestation, and we do go through a workup frequently to rule out any organic causes, but frequently, unfortunately, during this time, because they don't have access to mental health, and as your point, they don't have anyone to talk to, or they don't feel comfortable coming out and saying it, the first step is kind of ruling out an organic cause and discussing it could be anxiety or depression that's giving them these feelings of fatigue, weight gain, numbness.
Yeah, and I think what we saw is we showed some of the data from 2019, from before the pandemic. We have some significant data from during the pandemic. And so what we saw during the pandemic was that it went from 11% of people overall reporting symptoms that were consistent with anxiety or depression to 40% of people reporting those symptoms. A lot of stress-related symptoms. 11% reported some suicidal ideation, which is thoughts of suicide, not an actual plan, but a thought, which is very scary. We had two child and adolescent psychiatry trainees and a pediatric trainee on a couple of weeks ago, and we talked about kids and adolescents stuck at home, apart from their friends, whether they were straight or they were heterosexual, homosexual, transgender, didn't matter. We saw a lot more anxiety related unhappiness in these people, and then we know that there's a lot of financial insecurities, right? So Scroll.in reported today that in India, a huge population, big growing middle class in that country, the number one problem, other than direct health effects of COVID, is the economic impact that COVID has had with a lot of financial insecurity. So I think knowing that your emotional state may result in some physical complaints is really important. Tamir, access, right? You actually got a grant to start your company. So can you talk to us a little bit about your journey and what you hope to achieve?
Yeah, so we competed through the University of Chicago, which had an entrepreneurship competition in 2018. We came in first place in one competition, second in the other, and secured capital that way to open our first location. So in October 2018, we opened our first location in Long Island. And then over the last 2.5 years, we've scaled that to 9 locations, soon to be 14 in New York, New Jersey, and Illinois. And the mission was to provide in-network urgent care for patients with mental health complaints, primarily focused on those seeking medication. So what happens is if patients are going to the emergency room, when I was in residency, if they didn't meet criteria for admission, we would send them home. And the problem with that is that they would wait weeks until they saw a psychiatrist. And there was one incident where a patient committed suicide because she couldn't wait any longer. And that could have been prevented had she had somewhere to go. And that was kind of what inspired me to create a solution where we're seeing all these other urgent cares popping up all over. But none of them are willing to accept patients with mental health complaints. So there was a real gap, and that's where we came in, and we've been very fortunate. I mean, there's a ton of patients requiring our services, seeking our services, and we're excited to be there at the forefront of developing and pioneering a solution. So it's been quite incredible.
I think there's such an urgent need for this. So I'm a skull-based surgeon. I'm as specialized as you can get. And I was telling my team yesterday, last week, I had a patient in absolute mental crisis, absolutely depressed and anxious, and really with very few options. And I really appreciate people need these options. People need to know that there's a safety net to take care of them. there's a difference, Hillary, between what we call AMI or acute mental illness and SMI or severe mental illness. And can you talk to us about how you as a family physician, as an integrative medicine person, how you help people in these two aspects?
Sure. Well, if you're talking about in a crisis mode, when people come in and they don't really have, like Dr. Tamir Aldad was just explaining, the access is such a huge aspect of it. So frequently people will come in and they really don't know where to go. They can't find a psychiatrist. Maybe they have been in an ER and now they need to kind of get oriented with a provider who can help them. So frequently they'll come to me first and I'll try to help them access some therapy and different modalities. But initially I will have to help get them on, I'll help them with medication if that's a need, rather than sometimes there's a long-term plan. So it kind of depends on the situation of the person or the patient.
Yeah, and I think when we talk about coping skills, it's very interesting the material you can find online, right? So the NCAA, the athletic organization for colleges, has a graphic that they put out to help college kids have daily strategies that help them with mental health. So maybe Hillary, you can talk about this, and then Tamir, I'm going to ask you about the NIH strategies. So Hillary?
Hi. So just generally, there's just so many lifestyle changes and things that to help people when they are dealing with a chronic illness or anxiety, which is the flip side of depression. So they often go hand in hand, but just really trying to help them change their lifestyle and understand mindfulness and nutrition and exercise and things like that to just really help someone. And just understanding that it's not a choice that this happens to people, which frequently their family members, it's hard for them to even understand that. And just accepting that is a huge part of it, that it's not a choice. And there's so many things that we can do to help them. And it's a partnership, just changing their lifestyle and kind of adapting to that.
I think the one thing that I thought was missing from that was sleep, right? Uninterrupted sleep, where you're not having your phone wake you up all the time because somebody's out and doing something. Tamir, the NIH came up with some very valid coping strategies for people. And, I have to tell you, I have told people throughout the pandemic, stop watching the news late at night because you're just making yourself crazy. Like, record it, watch it tomorrow, right? So can you talk to us a bit about this, Tamir?
Yeah, I think the recommendations, first of all, a lot of them are easier said than done. I can tell you as a psychiatrist myself, I'm guilty of not doing some of these things, right? And it's easier to preach them, but then it does require a lot of effort to consciously remind yourself to be present, to be mindful, to make your mental health a priority. So that is definitely something that we need to promote. Both of these suggestions for coping skills are excellent. But at the end of the day, I think our approach really needs to be holistic, and there's a synergy if we approach this from multiple angles. So like, from my perspective, it's medication management, right? Making sure that if the symptoms are acute or they're severe enough, that there's medication on board, that the patient has therapists to teach them the appropriate coping skills and do exercises and help them, and also conduct actual psychotherapy to help them deal with any underlying issues, working with physicians like Dr. Beberman and making sure that the patient is actually physically and medically cleared and doing well from that perspective. So it isn't just one thing or two things, but really achieving mental health wellness overall requires multiple aspects and really requires us to work together to make sure the patient is in the best possible state of mind.
And I think a lot of thought goes into whether or not you start medication, right? And medication is not this magic thing where you take a pill and now you're all better. So I think, we have a slide that says that, you're going to think about the correct diagnosis, the potential side effects of the medication. Some of them, cause weight gain, for example, or hair loss, which can be more upsetting to the person. How old is the child? As you said, talking with their primary care doctor about their overall health, and then trying to incorporate counseling. So who is the right person for people to seek for that counseling? I'll start with Tamir.
Right. It's a tricky question. I would really tell somebody, go to the qualified professional that you feel most comfortable talking to. Really, if you have a great relationship with your family doctor, like Dr. Beberman, I would start there. If you have access to a therapist, you see a therapist, you have access to a social worker or a mental health counselor, a psychologist, and you feel comfortable starting there, that's fine too. And if you have neither and you want to start with a psychiatrist to explore where you should start, that's also appropriate. Really, the access to care issue is so bad that if you can get anywhere to talk to somebody, I would recommend you do that.
That's true.
I would hate for somebody to make the decision that, they saw on this show that I told them they should talk to a social worker, but they couldn't find one, so they went nowhere. So long as you can talk to a medical professional or a licensed mental health professional and you feel comfortable, start there, because that's something. And then you'll have a contact. And then from there, they can gauge the acuity of your situation and guide you. So making contact with someone is key. That's a huge intervention, especially if you're not in a good place, if you're in crisis. Even calling the crisis hotline, right? The National Lifeline, that's something. Calling your local mobile crisis unit, dialing 311 and asking for your mobile crisis unit in your county, that's something, right? So really just linking with someone is where I would start.
So, one of our viewers said that in Orthodox families, or in families who are perhaps not in the world as much, it's much harder, even, let's say within a certain community, to break out of there and get help. But I will tell you, I happen to be Hindu. I'm in New York City. I know some of the grand rabbis pretty well. They're very astute at how they refer patients. And I've talked to them, and I will tell you, from my perspective, talk to your rabbi. Like these are people, your priest, your religious and spiritual guide, they are incredibly knowledgeable about these things. They talk to people all the time, and they can know also when to refer, or when to call your Dr. Beberman, when to call your pediatrician or your family physician or your internist and say, I'm a little worried about this person. We have a study that came out of Lurie Children's Hospital in Chicago that really shows the devastating psychological effects, psychiatric effects of the pandemic on children. So almost 50% of parents during the pandemic had talked with their child's primary care doctor about mental health concerns. About a quarter of them said that their kid had actually used mental health services in this time. And unfortunately, 18% said they couldn't get care. So I'm going to ask you, Hillary, how, I love family practice. I have to say, my mother is a family physician. I love the fact that you take care of people from birth to death, right? It's the greatest. How do you change the way you counsel people when they are young, or when adolescents, or the parents of those children?
Well, I think with the adolescents, I think a lot of it is speaking to the family and the parents, who often don't understand why their child is acting a certain way or upset, or it can manifest in so many different ways. And like you were just saying before, medicine is taboo to a lot of people, parents, kids, and just bringing up the conversation of medication with any age group. Sometimes it's enough for just to kind of take the pressure off and make them think about what's going on. And then that can introduce other therapies like psychodynamic therapy, psychodynamic cognitive therapy, and the mindfulness and that whole bit. So I think a lot of times just broaching the subject is really helpful. and catapulting their kind of, getting help and just getting access and talking to someone, whoever it is, because it's really hard when it's your kid. And you would do anything for your kid. So
And I think you have an advantage as their family doctor because you've actually known this family. You understand more the dynamics within and between the family and what the person was like in 2019 and 2018 and what has happened since then. And I think Sandra Lefkowitz says, the light is now shining on mental health. And, there is clearly fragility in mental health, that it's okay to seek care. And I think that's part of what we started with. How do we remove stigma? How do we not call the person who has depression lazy? How do we not call the person who has anxiety, nutty, right? How do we use the right words and use the compassion? We are live on Facebook, on YouTube, on Twitter, on Sri Srinivasan's LinkedIn, on Scroll.in. We are carried on WBAI 99.5 FM and WBAI.org on Mondays from 2 to 3 p.m. Please like and share and tag your friends who would be interested in this discussion. I can't imagine who would not be interested in this discussion. I wanted to talk a bit about mental health among healthcare workers. So, we got all these claps and these pots and pans banging and whatnot, at the height of the pandemic. But, the burden on healthcare workers is really high. In general, the emotional burden. I mean, Tamir, you talked about, I started to cry. You talked about a patient who you tried to get help for, and unfortunately they committed suicide before they could get that help. So those stories never leave us. And so Chris Ramanathan writes in that, what about people who are afraid to get help because they are going to be treated differently by their boss or by HR. So let's first talk about burnout, and then let's talk about why people don't seek care. So Tamir, can you help us with this slide? Can you tell us what burnout is and who it affects among healthcare workers?
Sure. So that comment actually is a perfect segue to this. One of the biggest reasons we see burnout among healthcare professionals is because they think there are consequences to getting help. So that if they already have the insight and can identify that there's an issue, a lot of times they'll be hesitant to even seek help because they don't know what the ramifications could be to their profession, their career, if there's any sort of reputational risk associated with getting help. So there's a lot of, like I said, apprehension. The other issue, though, is there's also limited insight and ability to self-reflect and identify that there is an issue. A lot of times we see this with physicians in training, those going through residency and fellowship. Those that have gone before them and graduated many times created an environment where everything's acceptable and you have to do whatever it takes, no matter what, to get through the program. And what that's created is a culture in their training where people can't identify what is a safe and appropriate threshold and when they've exceeded that threshold, because you can't gauge, because it's like a moving target, right? If someone tells you everything's acceptable, then how are you supposed to know when it's not? And because of that, people are not calibrated going through training to know if they've reached a point of burnout, if there is some sort of mental health impact on their well-being. And some programs condition you that even if you do have issues, that this is just a part of training. Everyone did this before you. You have to continue doing it. And what we need to do, and what we and programs are doing this. The ACGME is working towards this. And it's not like this is an ignored issue that's not acknowledged. People know this is a problem, and there's active steps to improve it. But nonetheless, there's a lot of room to further grow here and help training physicians recognize what is an unsafe working environment? What could be impacting your mental health? What are symptoms you should be aware of, and what you could do to improve your well-being?
Yeah, I'm old enough that when I trained, we were every other night on call in general surgery at NYU in Bellevue, and our chairman said the only problem with that was we missed half the really good cases. Right. So I'm like,
Right.
oh my God. And I remember I took a city bus up to my apartment after about a 40 or 48 hours in 2 days, right? So about a 44-hour shift. And I had to be back, 3 hours later. And I just fell asleep on the bus and woke up, 60 blocks north and couldn't quite figure out how to get home. So I think, wow, I was fine, luckily in the middle of the night, in Harlem in the 80s, but not a great scenario. And you're right. We were taught to accept all crazy stuff. I think one of the slides that we had earlier showed that, in fact, burnout is equally bad, over 45% in all specialties. So it's not like there's an easy specialty or a hard specialty. I think those of us who do it, we take this as an avocation. We take our patients into our heart. 76% of emergency medicine residents have symptoms of burnout. Among neurosurgery residents, we have high percentage of people with emotional exhaustion, feeling unworthy, and unfortunately a high percentage who don't feel like their work is valuable, which is, crazy if you're their patient. So I think the reason we pay attention to burnout and to the emotional health of physicians now, which I wish we had been doing forever, is because that affects our patients. So Hillary, can you talk to us about this? I think you and I talked about your training and
Sure.
different areas where you've been in practice.
Yeah. So, I mean, to both your points, I mean, just being a resident or trainees in medicine, when you're an intern and a residency and you're working every other night on call or every third night, and you could be working 80 hours a week and 100 hours a week, and we're trained to just, this is how it is. You could be exhausted, not sleeping, trying to take care of patients, and you can't complain. You just have to accept it. And the same, and now I see it again. It's almost just come full circle with COVID. We're working all the time. It's, our patients are going through so much. We're trying to help them. And it's exhausting, but you kind of just have to go through it. You're surviving to get through it. And in that mode, we really can't take the time and say, I'm exhausted, I'm tired, I'm nervous. It's just almost, we were trained not to be like that. And it's okay to sometimes be a little reflective and take some time to think about ourselves. And I think physicians especially don't, because we're just in that mindset of, we got to go on, we got to keep going, and don't think about it. You have to persevere, and you got to step back sometimes as physicians, all of us, and just really take the time to think about our mental health.
Yeah, I mean, I was just thinking that, one thing that's really important to point out is that healthcare professionals should really only look at themselves when they assess burnout and not compare themselves to their peers.
Sure.
Like we're looking at that table that you just put up about subspecialties, and there's a risk there that somebody who might be like a PM&R physiatrist will feel less comfortable coming to telling you he or she has burnout versus somebody who might be an ortho or ENT or gen surge, because they just think that, well, I work 9 to 5, or I'm on call every fourth night and they're on call every second night, so maybe I can't be experiencing burnout because this other specialty has it much worse. And that's terrible. We really need to promote that at the end of the day. These people, everyone's an individual, things affect people differently, and we have to meet you where you are. So same thing with a patient. If somebody is completely decompensating because their pet died, doesn't matter if you were able to, let's say you're thinking as a provider, when your pet died, it didn't affect you. That doesn't matter. That's irrelevant, right? It's how is the current work condition affecting that person that matters. So it's important to promote that too, as we're promoting education, that you're an individual, and if you're burnt out, nothing else matters. Doesn't matter your specialty, doesn't matter your hours, doesn't matter if you have no overnight call at all. You're burnt out, period. You're burnt out, and that's okay.
So I think this segues back very well into how Chris started us with this conversation and what you said, Tamir, about why physicians don't seek healthcare. And so there was an article in Kevin MD by a physician a couple of years ago that talked about why it is that when we are anxious or depressed or have something else going on, we don't seek mental health. And, primarily, if we see a psychiatrist and if we are on meds, we have to write that down every single time we re-up our hospital appointment, we re-up our professional liability insurance. Like, everybody wants to know about our personal life. Nobody wants to know if I have hypertension or diabetes, but they want to know if I have what is essentially treated mental health issues. So Tamir, can you talk to us about Dr. Weibel's article and or her thoughts?
Yeah, so I think it's really a case by case type of situation, and also you do like a risk benefit analysis too. There is, it isn't as black and white, I think, as this list in terms of what we do and do not divulge to organizations in terms of protected health information. We do in psychiatry have a huge responsibility and obligation to our patients to protect their mental health records even more than other records. We have the right to not allow a patient to see their therapy notes, whereas other medical specialties don't do that. So the first thing is to do a real risk-benefit analysis. Depending on the acuity and the severity of your symptoms, it might be better to get help than not at all. And then the second is to really speak to your mental health provider regarding your situation. Is there something going on with HR? Is there something going on with your employer? What can and can't be done? What will and will not be shared? Is important, right? I've had patients who were airline pilots, and that was a big issue, and we had to approach that differently versus I've had school teachers, and that's completely different. So, by profession, it also changes in terms of what I can and cannot share and what I will and will not share. So it's difficult to paint it with a broad brush, right? So,
Right. And I think part of this opening this dialogue, and I must say, I think the younger physicians and the trainees are much more open to being realistic about their mental health and the importance of it when we take care of patients. But I think, maybe working within your hospital system to say, why do you need to know this? Like, what this may be doing is discouraging people from getting care that they need so that they can go on to provide care. Hillary, we all take care of fellow physicians. We take care of people who are not physicians. And, there's this whole concept of, even though mental health may be covered by my insurance, what if HR tells my boss? What if somebody says, don't give her this project because, turns out, she's got anxiety. How do you help your patients deal with that aspect?
Well, I think with most of my patients, there's HIPAA privacy that is followed, and I don't.
I'm just going to say HIPAA is the health insurance
information protection. So there's a confidence agreement between a physician and a patient, and really the information isn't shared. It's not allowed to be shared with someone's boss or where they work or anything like that. It's what they tell me in the room is private, and nobody can know about it. Not their family, not even someone who works that's why our charts are protected. So someone else can't even look at the chart in the room. Another doctor even. Like, I can't look at my staff's chart unless I have permission, because it's really important that the patient feels safe and comfortable talking about whatever they need to. And it's private and that they know it's confident.
Yeah, and I think that this is really crucial, right? And especially, I think, with the electronic health record, as onerous as it is, and as much as we all hated it in the beginning, and we've certainly gotten used to it, we know who has accessed somebody's chart. And I think that's really important. So Tamir, can you talk about that? Because you have healthcare providers working in 3 states with 3 different licensure and rules. How do you and your company maintain control of that very important protected health information?
Yeah, so it's a huge priority of ours to protect patient records, maintaining compliance both with local, state, and federal regulations that protect health information, and maintaining patient privacy in terms of those records. From a electronic medical record perspective, it's a IT security issue more than anything else, and falls on the IT department to assess if anyone's accessed the patient that doesn't belong to them. So we make sure that our providers and those who are in touch with patients are only accessing the patients that they are actually taking care of, and that that it's appropriate that they know that information. And then we have agreements with third-party organizations that also need to access that information. So it would be insurance companies or a billing company. We have agreements in place that they understand the requirements of protecting that information and the sensitivity of that information as well. So a lot goes into, from an IT security perspective, making sure that patient privacy is a priority, and then also from making sure our team is properly trained to recognize and appreciate how important that is to us. So from both those perspectives, we make sure that we're covered and patients are protected.
I think we've covered so much ground today. Mental health issues are across the spectrum. We see them in all people. We see them at all ages. And I really appreciate the 2 of you taking the time to talk about this. We haven't even gotten into the differential of mental health issues among different races and ethnicities, even in the United States, let alone worldwide. There's a graphic that Marina pulled up, which we thought was very, it's very evocative, right? So 1 in 4 people overall are affected by mental illness. Shockingly, almost 9 million adults in the US have suicidal thoughts on a regular basis. And suicide is, in fact, the 3rd leading cause of death in the United States. Children with anxiety disorders are the least likely to receive treatment. 1 in 30 people have some degree of PTSD or post-traumatic stress disorder. And then, of course, we are aware, and we've been made painfully aware through the pandemic, that people of color receive less care, have less access to care, mental health care, physical health care, vaccinations, COVID care. So there's quite a bit to be done. But I think the beginning of this is dialoguing with smart people who care about people like you. We have just a few minutes left, so could you possibly give us a few takeaways for our audience? And I'll start with you, Dr. Hillary Beberman.
Sure. Well, what I would like to say is that just look at the slides. You're not alone. How many 1 in 4 Americans are affected by this? And also, it's not a choice. You can't just snap out of it. So that's important to remember that. And the third thing I would say is it's not a life sentence. It's treatable. And there's many modalities to help you. And we're here to help you. Whoever you can find to help you is available with different treatment options. It's out there. So
thank you. Very holistic and family medicine approach, which I very much appreciate. Dr. Tamir Aldad, psychiatry perspective takeaways?
I think one of the biggest things that I want people to know is look in the mirror and take a very honest look at yourself, and be able to tell yourself and recognize, that you feel a certain way, and acknowledge that is important. Really being honest with yourself there. knowing that talking to any mental health professional is a start. So it's important to seek somebody, and there are people anywhere. We talk about children, so it could be schools, your teacher, your guidance counselor, your family physician, a psychologist, a therapist, psychiatrist, whatever. Someone in the field to talk to is important. And lastly, having hope and knowing that there are many, many people who felt the way you felt and today are doing great. And there's no reason you can't do that too.
Thank you. We have a few seconds where I can still talk to you. And we've had a couple of school nurses on the show. And I think one of the things we experience is the closures of schools took away an essential safety net from many, many, many children. So Hillary, let me ask you, how as a family physician do you interact with school nurses, and what has changed in this pandemic year?
Well, this has just been so hard for children, families, teachers, everyone, and it's taken a huge toll on kids. And I'm so happy that things are coming back to normal a little bit, and they can interact with their peers, and they're just being in a normal environment at the end of the year. But we have been able to interact with staff, with nurses, with parents. I mean, through Zoom and things like that. But everything is virtual, so it was different. But it will be better now that they're back and able to really get the support they need in person, hopefully.
And then Tamir, just a last question for you. Difference between in-person counseling versus online counseling through a electronic platform?
We had to make online counseling and telehealth and video conferencing work over the last year. We're retransitioning now back to our brick and mortar locations, which is great. So there is an added benefit to seeing a patient in person. What's interesting, though, is you do pick up on some things when you do video conferencing that you wouldn't pick up on otherwise, in terms of seeing where the patient's living, how they're living, what the conditions are like, their grooming habits. So you do get some clues that you wouldn't get, like you would in an office visit. But what you don't get is the level of control. So if a patient is acutely symptomatic, from a safety perspective, there's less you can do if you have them on video conference versus having them in your office. So it's there's benefits and to both, but nonetheless, we do want to be able to have the flexibility to offer patient both in person and virtual, where we think that's kind of all encompassing. So that's where we're headed.
Thank you both very much. This has been a wonderful conversation. I've learned a lot, and I'm sure our guests have learned a lot. Somewhere in the middle, two of our guests were counseling each other about make sure you get healthcare, two of our viewers. So thank you so much for spurring good activity among our viewers. We have had the pleasure of meeting Dr. Hillary Beberman, who is a concierge family physician, an integrative and women's health physician in Great Neck, New York, and Dr. Tamir Aldad, who is a psychiatrist and CEO of Mindful Urgent Care, which has a psychiatry practice with offices in New York, New Jersey, and Illinois, where you can actually get access to a certified, qualified mental health provider within 24 to 48 hours. Thank you both so much for being here. Thank you to our sponsors, ENT and Allergy Associates, with 40 locations in the greater New York metro area, where you can also access ear, nose, and throat and allergy care within 24 to 48 hours if you need it by going online. And to our newest sponsor, Comfort Ear, which I have to say is a terrific soothing eardrop for dry, itchy, scaly ear canals when there's no infection, and really nice to use and makes you feel less irritated by your ears. If you or your company would like to sponsor She's on Call, please reach out to our co-executive producer, Shri Srinivasan, and his email is shri@shri.net, which is SREE@SREE.net. We want to thank our production team, without whom none of this could happen. So thank you so much. And I'm going to read their names as we close out for the main calendar year. We have producers Rose Horowitz, Wagner Menon, Julia Weeks. We have our video highlights by Keval Ramanathan. Our design director is Shushti Hebar, and our beautiful voiceover that you hear at the beginning of each show is by Nicole Lewis. And we are so grateful to them for making Marina and myself look real good. We are taking a little bit of a break for the summer, so we'll have one show in July and one show in August. Our July show will be on July 18th, and our August show will be on August 22nd, and then we'll be back with weekly shows after Labor Day. So please like and share and follow and get reminders and join us, and have a great, healthy, safe summer. Please get vaccinated. Please be careful.